Good morning, good afternoon, and good evening for the trainees who have joined from all over the world in our urology exam preparation YouTube channel. Today we are doing our 10th episode of mock exam and we are going to discuss various bladder cancer scenarios. We have our first trainee. Thank you for joining.
Thank you so much.
You have a 78-year-old gentleman presented with visible hematuria and your colleagues have performed hematuria clinic flexible cystoscopy which showed bladder lesion in the floor and he was further referred for CT scans and you are reviewing him in the clinic to tell the diagnosis and list him for further procedure. What features you will explain to him?
So I will see him in the clinic in the presence of a cancer specialist. I'll tell him that unfortunately his flexible cystoscopy has shown a tumor in the bladder, and I had to see what's the if there is anything abnormal in the CT urogram. If it is normal, then I'll tell him that we have to do a resection of the tumor in the bladder through an endoscopic procedure. The aim of the procedure is to remove the tumor. At the same time, it can tell us what type of tumor it is and what's the stage of the tumor. Um, I'll tell him that the risks involved are need for bleeding, need for transfusion, need for catheter, risk of bladder perforation. Very unlikely because it is a posterior wall tumor. However, I'll take the consent for that as well. And I'll tell him that it is better to give a single course of chemotherapy into the bladder. I'll tell him that that will prevent the recurrences. And I'll support my counseling with a Bow's information leaflet.
Okay, what is the evidence between single course chemotherapy?
So that is the Sylvester et al. Article, which proved that a single course of mitomycin can decrease the absolute risk reduction of recurrence by about 30. Sorry, I had to reframe it. It can decrease the relative risk reduction by 39%, absolute risk reduction by about 12%, and the number need to treat is around 8.
Okay, I'm going to share the CT scan images.
Mm-hmm.
Just give me a minute.
Mm-hmm.
What other blood and urine investigations you will arrange for him?
So there are, the blood investigations include the FBC to see for hemoglobin and white cell count, coagulation parameters, and EGFR and creatinine. There are options of doing urinary biomarkers like NMP22, BTA, STAT, BTA track, immunocyte, or Eurovision. Uh, Urine cytology is also recommended, however, mostly in cases where we cannot find any tumors, but there is persistent hematuria, in which case we can do the urine cytology as well. For this tumor, because there is tumor that is visible in the bladder, there is less value for a urine cytology.
Okay, what CT protocol you will use?
I'll use the CT urogram protocol, which contains a non-contrast phase, a nephrographic phase, and a delayed phase. So the nephrographic phase, the CT scan is taken at 100 seconds after the contrast, and delayed phase, CT is taken at around 10 minutes time.
Okay, are you able to see the pictures now?
Yeah, I can see that. This is a
I'll come
coronal.
from the top. Yeah, okay, yeah.
This is a coronal section of a abdominal pelvic CT. So I can see the kidneys now, and the most striking abnormality in the CT scan is multiple cystic type of lesions in both kidneys. The one that is on the lower part of the left kidney is more prominent. I could see the tumor in the bladder as well in this section.
Okay, let us see the axial phase.
So this is a delayed axial phase of the same CT scan. So coming from above. I could see the contrast clearly in both ureters. And now, yeah, the contrast I can see in the bladder, and there is a filling defect in the bladder, which corresponds to the history and the flexible cystoscopy findings.
Okay, so what are you going to do now?
So I'll review this CT scan in the MDT, make sure that there is nothing abnormal with those lesions in the kidney, and confirm that it is indeed cystic only. We'll also confirm that there is nothing abnormal in the pelvic calyceal system. If it is only the tumor in the bladder, then I will counsel and list him for a urgent transurethral resection of bladder tumor plus intravesical mitomycin C instillation.
Okay, so how will you do the TURBT? The patient is consented, draped, and anesthetized, and everything is ready. So, what precautions you will take?
So after confirming that the antibiotics has been given in the lithotomy position, I'll start with the examination under anesthesia. Then we'll do a cystoscopy, carefully looking through the urethra, prostatic urethra, and in the bladder. Once I'm in the bladder, I'll make sure that this is the only tumor that is there, and there are no other tumors. Will identify my landmarks, both ureteric orifice and the relation of the tumor in relation to the ureteric orifice and the lateral wall. Then I'll insert the resectoscope, Iglesias continuous flow resectoscope, and then start resecting the tumor like in a fractionated method. I'll make sure that all the tumor is resected, and the deep resections of the bladder muscle is also done. After achieving the hemostasis and making sure that there is no perforation, I'll insert a 3-way catheter and then instill 40 milligram of intravesical mitomycin C, which I will keep it for 1 hour after clamping the catheter. I'll make sure that the patient is transferred back to the postoperative ward safely. I'll make all the I'll complete the operation notes by a bladder diagram and carefully recording all the findings, and will give clear postoperative instructions in the operative notes.
Okay, what may be the histology in this patient?
Mostly it is transitional cell carcinoma, and in the histology, I'll also be interested to see if there is a muscle present, if the muscle is involved or not, the grading of the tumor, and if there are any variant histology.
How can you risk stratify the patient based upon these facts?
So according to the NICE guidelines, there are 3 risk classifications: low, intermediate, and high. So if it is a solitary G1 or G2 PTA less than 3 centimeter lesion, if all these criteria are met, it is low risk. Any high grade tumor, any tumor with T1 involvement, CIS, all these are high grade tumors. In between, all the other tumors will come in between into the intermediate risk. I know, I am aware that the recent EIU 2021 guidelines is different now, with the inclusion of very high risk category as well. And there is an online calculator the EIU provides for risk categorization and to predict the 5-year progression regarding each type and stage of the tumor.
Okay, what is included in the very high category?
It is the age more than, I mean, there are 3 main criteria. One is the age, and then the type of tumor, and the variant histology, and CIS.
Okay, good. And let us assume our patient histology is G2, PTA, low grade, and the size is say 28 millimeters. So what are you going to do now?
So this G2PTA low grade will come under a low risk non-muscle invasive bladder cancer. He already has had his intravesical mitomycin C. So I'll see him in the clinic again with the presence of cancer nurse specialist, and then we'll tell him about the diagnosis and the risk categorization. I'll tell him that The further management plan is to have a follow-up flexible cystoscopy at 3 months' time, and if it is clear, then a further follow-up cystoscopy at 9 months afterwards, a total of 12 months. I am aware that there is a difference in the guidelines between NICE and EAU. NICE guideline says that if for this tumor, low-risk tumor, if there is no recurrence at 1 year, we can discharge the patient back to primary care.
Okay, good. We'll stop there. I think you did very well. There are no concerns. This is a kind of a very baseline scenario, and there is no reason, especially for you at this level, to make any mistakes. The only thing I can add is I will introduce the Macmillan nurse after flexi itself. There is no real reason to wait till you get the histology. And similarly, even for renal cancers, once you see a CT scan which an obvious RCC, you can involve the Macmillan nurse directly. Only for prostates, we don't include them when we have increased PSA. We wait for histology. Okay.
Thanks so much.
Yeah, and the other thing is you haven't brought in the MDT treatment. MDT after histology. You said you will see the patient. It's very small issue, but in case if the examiner has got the multi-department meeting discussing with pathology and radiologist, everything there. And after the T or BT, you can again touch upon the imaging to make sure that there is no metastasis and it's an organ confined tumor, so that your issues are complete. Okay.
Thank you.
Yeah. And when you're discharging the patient, you can heavily rely on NICE guidelines. This is a UK-based FRCS exam, so you can confidently say, I will arrange a flexi in 3 months' time and 12 months' time from the date of the first inclusion. As long as there is no other high-risk features, I'm happy to discharge him as per the NICE guidelines. You can mention one line about even though I'm aware that EAU guidelines differ. There is no need to go anything further because you are expected to say this and you're expected to do this in the practice also. Okay.
That's it. Thanks so much.
Good. So we'll go for the second trainee. Are you ready now?
Yes, Mr. Dhanashri.
Good. Your time starts now. You have a 68-year-old gentleman presented with visible hematuria. He is a heavy smoker. He had a cystoscope which showed very poor vision and no obvious tumor, and your registrar was not able to ascertain what is happening. And so what are you doing? The cystoscopy was stopped, patient was brought to the recovery room, and by the time you reach, how will you handle him?
So I'll review this patient in the recovery room, and I'll first try to ascertain the reason behind why the flexible cystoscopy there was poor vision. It is quite possible because of multiple reasons. One is that there could have been a lot of blood, but since this is the recovery room, can I just ask if this was a flexible cystoscopy or a rigid cystoscopy?
Flexible cystoscopy.
Okay. So if there was a lot of blood in the flexible cystoscopy, then there are two options. Then I could talk to the patient and see if he's happy to go back. I can try emptying the bladder and then refilling it with saline, and that can sometimes improve the vision. The same thing can happen if there's a lot of turbidity in the urine, which could be because of infections or could be because of some debris which is there in the bladder. Could be a result of stone and some flakes in the bladder, which can produce this. The same emptying the bladder can solve this problem. I'll discuss this with the patient. If he's happy to get it done today, then I'll do it. And if the staff is happy, otherwise I'll rebook another date for him within 2 weeks. If he has an infection, I'll give him adequate treatment for the infection. I'll check his urine dipstick for that. So these are the options. I'll discuss with the patient and I'll take a final decision then.
Okay, your registrar is quite a competent person, and if the registrar feels that the vision is not good, you can certainly believe that they have done everything possible under the sun to get the picture. And patient felt very uncomfortable after the flexi. He is not interested in having another flexible cystoscopy under local anesthesia.
So in this case, I'll take a brief history from the patient so that I can certain other symptoms that he has. I'll include symptoms of other voiding and storage LUTs. I'll check his occupation, any prior urological procedures, any prior treatment for other cancers, including radiotherapy, his other comorbidities, his ASN performance status, his alcohol intake, and then I'll do a brief examination of his abdomen after taking verbal consent in the presence of a chaperone. And I'll also request basic investigations, including full blood count, renal profile, and I'll then discuss the option of GA cystoscopy with the patient, since he's been quite uncomfortable with the flexible cystoscopy and it's been difficult to see with the flexi. So with GA cystoscopy, we can expect better vision, quicker emptying, and since the patient will be under general anesthesia, rigid cystoscopy can be done, and that will give us better vision. At the same time, I'll also consent him that if we find a tumor during the GA cystoscopy, then I will consent him for a TRBT as well.
Okay, examination findings are quite non-contributory. His blood investigations were normal. His urine investigation doesn't show any infection. You have sent the urine for cytology, which showed presence of malignant cells. And any other imaging you wish to do before going for TRBT?
So now, since he has visible hematuria, I will organize a CECT of the chest abdomen. I'll organize a CT urogram, and then I'll take a further decision about. So I'll review this before the TRBT.
Okay, I'm going to share the pictures of CT scan. You can see now?
Yes.
Okay, so I'll just move it from the top to bottom. I'll do it again.
Yeah.
Okay.
Yeah. So this is a CT urogram. I'll confirm the patient details and the date before commenting on the CT. I can see the kidneys are normal, the pelvic ileal system is normal, the ureters are normal. There is a large diverticulum in the bladder, and there seems to be a mass in the diverticulum, although it's not yet filled with contrast, so I can't see a filling defect. But it seems to be there seems to be very mild perivesical stranding around the diverticulum. So this could be a TCC in the bladder diverticulum. So I would like to go ahead with the previous plan, but along with that, I would also organize a CT of the chest for this gentleman to rule out any chest metastases. However, I'll not wait for it to allow to cause any delays to the TRBT.
Okay, his CT chest was normal. So TRBT, how are you going to approach him? Patient anesthetized, consented, prepped.
So in an adequately consented and counseled patient after the WHO checklist, I will do an examination under anesthesia first. Then upon emptying the bladder, I'll do a rigid cystoscopy with a 22 French sheath. I'll examine the entire urethra, the bladder neck, and the prostatic urethra. Then I'll do a systematic rigid cystoscopy. I'll enter the diverticulum and examine the entire diverticulum as well. And then I will. Prior to this, I would have discussed with the anesthesiologist during the check-in, during the sign-in, that since this is a diverticular mass and it seems quite lateral, I would prefer to have the patient under GA and relaxation. So now I'll shift to a 26 French resectoscope, and using and then I'll do a fractionated resection of the mass in the diverticulum. I'll not go very deep, as diverticulum does not have a muscle layer, and so I'm not going to look for resection of the muscle. I'll make sure that I have enough for biopsy, achieve hemostasis, and then empty the bladder, and then do another EUA, and finally put in a 3-way catheter and start irrigation. I'll make sure that I've sent the histology, booked MDT for this patient, and given adequate post-operative instructions. So that'll be my plan during the day of the surgery.
Okay, his histology shows G2PT1 with evidence of CAS. What is your plan?
So I will discuss this patient in the MDT, where I'll again discuss the imaging and the histology. In addition to this, I will also ask for presence of any lymphovascular invasion. Although in this scenario, it is since this is a diverticular mass, I would the most likely outcome of the MDT would be to offer the patient radical cystectomy and lymph node dissection. So this is what I would, once I have the results of the MDT, I will discuss this option with the patient. I'll once again assess in my MDT clinic in the presence of a cancer nurse specialist. I will discuss the treatment option, this particular treatment option with the patient.
Why for diverticular tumors you prefer radical cystectomy rather than any other modalities?
So in diverticular tumors, since there is no muscle layer, it is then these tumors are at high risk for progression. So in this case, I would offer him radical cystectomy rather than BCG or intravesical therapies.
Is there any role for diverticulectomy since the tumor is present only in the diverticula?
Not according to the guidelines, no.
Okay, you can complete the answer if you want.
Oh, sorry. So according to the guidelines, there's no role for diverticulectomy and bladder tumor excision unless the patient is very keen on preserving the bladder. Then I can discuss this option with him, but it's not something that is done routinely.
Okay, good. Good presentation. How do you think you did?
The initial part threw me off. Although it happens, but I wasn't expecting this in the exam, so yeah, it threw me off initially. And it was a diverticular tumor, so yeah, this is how I think we'll go. I'm not sure. I mean, I should have tried to come to the radical cystectomy part a bit sooner. I think I wasted time, but I mean, it's a bit difficult for me to pinpoint where I wasted my time.
You haven't wasted much time. I think the progression, everything is at good speed. Sometimes you will have a questions which is more of managerial related decision making that is very important for a consultant level person. So for example, how I will handle this is when a registrar is doing a flexible cystoscopy and says the vision is not clear, obviously you know why the vision is not clear in this patient. He has diverticulum, which shows possible bladder outlet obstruction, which shows there may be some stasis of urine, and that's why the vision is not clear. And especially for this tumor, sometimes even if you do a good wash when the patient is under local anesthesia, you may not be able to clear all the urine which is getting fed from the diverticulum into the main bladder cavity. So that's why it is failed. So what you can do is you can bring in like I will be aware of my registrar's competence. If the registrar is a senior most person and if he feels that it's a very difficult cystoscopy, I will go ahead with GA cystoscopy, proceed plus or minus T or BT. But having said that, if the registrar is in the early stage of the training, I will try to convince the patient whether if he is happy for you to try a flexible cystoscopy under local yourself. So I just want to touch that managerial decision making in this scenario so that you guys are not feeling very uncomfortable when any of these kind of scenarios comes in any of the table. Okay. And CT scan, when I show the CT scan, you try to observe a lot and then talk in the end. And I always encourage people to talk as you see. I know there is a small possibility you may make some mistakes because you don't know the full cut. But the easiest way in exam is I wish to see all the cuts in different phases, but I will narrate as I see. And in exam, sometimes you may be given only 1 or 2 cuts. Okay.
Okay.
So those periods are very important. Maybe around 15 seconds, 30 seconds, that makes a lot of difference. And glad that you mentioned, I mentioned about cytology, so you should have taken a clue from the cytology.
Yes, I didn't mention you first.
Yeah, and I said the cytology was positive, but you haven't really used that much. So by using that,
Okay.
you can say that there is a good possibility of high-grade tumor or CIS. So while consenting, you can confidently consent for T or BT because there should be something happening. I agree with you. For diverticular tumor, the role of diverticulectomy is very less, and it's always nice to go for the radical cystectomy, of course, including the diverticulum also. Various reasons, as you said, thinned muscle or absence of muscle, which can result in quite rapid extravesical progression, and also the field effect. It's better to do a cystectomy as a whole because the rest of the bladder has the equal propensity of forming a cancer in the future. And glad that you brought in examination under anesthesia. That's a very important part for all the T or BTs. There is no role for mitomycin. That is fine. I thought you will spend a little bit on the challenges which may arise because it's a diverticular tumor. And since you had the CT scan prior to T or BT, you can discuss few things like I will try to get a thinner receptoscope because sometimes the diverticular neck may be quite tight. So as I said, you can't get the normal straightforward bookish T or BT in every scenarios. There may be some scenarios, and you will still get 6.5, 7 without mentioning that. But if you role play that specific scenario, giving importance to how you will handle a diverticular tumor, try to get a thin resectoscope. It may not be possible in real life, but at least theoretically speaking, you can bring anything to the theater, isn't it?
Yes.
And the diagnosis is G2PT1 CAS. That's quite a high risk tumor. There is a role for BCG, but how much the BCG will work in diverticulum is a question, and diverticular tumors are very progressive. So you can discuss the option of BCG with highly leaning towards radical cystectomy. That may be the better option. Again, as usual, Macmillan nurse and MDT needs to be brought in. And whenever there is a failed cystoscopy, already there is a indication for visible hematuria CT urogram, isn't it?
I should have thought.
Even if the CT,
the initial thing threw me off completely. I missed that part. So urine cytology and CT urogram I should have brought in straight away myself.
Even if the cystoscopy is a successful normal cystoscopy, you will be doing CT urogram anyway.
Exactly.
So by doing a CT urogram a priori, that gives you a good idea about whether you want to lean towards GA cystoscopy proceed, GAT or BT, etc. So try to get as much of information like in the investigations before putting the patient to GA. Flexible cystoscopy under local is a type of investigation, so that is fine. But when you are committing for GA, try to get as much of information. If the patient had, for example, a lesion like this in the pre-T or BT CT scan, abdomen contrast, I will always try to get CT chest also, because anyway patient need a CT chest. You are placing the patient under anesthesia. What is a possibility? Patient may have a multiple cannonball metastasis in the lungs, isn't it? So it's nice to have a CT scan that will be helpful for the anesthetist during the T or BT also. So all the non-invasive investigations you should prepare as much as possible before any anesthesia procedures, and you should express it in your words. That examiner should get a confidence. Okay, he wants to make sure that he has got completion of imaging, including chest, especially in this patient with cytology positive everything, before placing the patient under anesthesia. You should prove this to the examiner.
Right.
Good. Can we go for the third scenario?
Can I ask a question, Mr. D?
Yep.
Can we make a statement that diverticular tumors are treated as muscle invasive? Is it correct?
We can make a statement, but the way by which we discussed, that's very nicely worded. Diverticular tumor will be having thinned out wall. There will be absence of muscle or thinned out muscle. So there is a high possibility of early extravesical spread. And the other thing is sometimes there is no muscle. So for example, this is a high grade tumor with high propensity of muscle invasion. You can't prove that because there is no muscle, and the next stop will be a direct T3 and extravesical spread. So you can say it can be treated equivalent to muscle invasive tumor, but if you say the thinned out bladder wall which can propense the lesion to spread extravesical early, that equally means in a better wording.
Because that's the reason why we are taking the CT chest up front, isn't it? In non-muscle invasive, we don't need to.
Yes, yeah.
Yeah. Okay.
Yeah, CT chest is mainly because of the diverticular tumor and high grade tumor, CIS. So, yeah, just for completion.
All right. Okay. Thank you.
Good. Let's go for the next scenario. Is it okay?
Yeah, sure.
Good. Your time starts now. You have a patient who had a TURBT. The histology is G2PTA, muscle not involved. You are discussing this patient in your MDT. This is your patient, but the TURBT was done in your absence because of your annual leave. So, a fit 68-year-old woman with G2 PTA muscle absent. Prior CT scan showed a 4 centimeter bladder lesion and not much evidence of any muscle invasion. So, how are you going to take it further?
I would discuss this in the MDT. I need few further information in the MDT. One is whether G2 high grade or low grade, and muscle not involved means whether the muscle is present in the risk sector specimen or not. I would ask the pathologist, and any number of lesions. How many lesions were there? Is it multifocal or solid tumor? And if there are any variant pathology found, such as micropapillary lymphovascular invasion or sarcomatoid variant.
Okay, no variant histology. It is G2 high grade PTA muscle absent in the specimen. The previous CT scan showed solitary lesion 4 centimeter.
So based on the NICE guideline risk categorization, this comes into intermediate risk cancer, non-muscle invasive bladder cancer. I would see this gentleman in my clinic with the nurse specialist, and I would explain him the histology findings, and my treatment would be to offer him 6 doses of intravesical mitomycin C.
Okay, is your staging complete?
Yes, in non-muscle invasive cancer, based on EA guidelines, we don't need any further staging unless we are going for radical cystectomy.
Okay, why do you want to give mitomycin?
The mitomycin C has proven that it prevents it reduces the recurrence of the tumor, although it has not has effect on the progression. But in the intermediate risk tumor, the most common management that we perform is the mitomycin C. But I'm aware that intravesical instillation of BCG is also an option. But in my practice, we offer mitomycin C.
Why you are giving 6 doses?
That is the accepted in the guidelines.
Okay, so after mitomycin C 6 doses, what is your plan?
He will have an intermediate risk follow-up plan. So usually he will have a CT scan, a flexible cystoscopy in 3 months. And after that, every 6 months for the first 2 years, and then annually for 5 years. And based on the response and patient's factors, I will decide whether to discharge or continue follow-up further based on the NICE guidelines.
Okay, so flexible cystoscopy in 3 months showed presence of bladder lesion and measuring around, say, again 3 to 4 centimeters. And patient also has symptomatic with episodes of hematuria in between.
So this shows there is a tumor recurrence. So I would book him for general anesthesia and TURBT again, and will plan my management further based on the histology.
Okay, any imaging you want to do?
I would like to repeat the CT urogram. Sorry, I want to clarify something. In the first instance, I assumed that this patient had CT urogram in advance. That is my practice. That's why I said that we don't need any further staging. But at this point, if there is a recurrent bladder tumor, and if CT urogram has not been done, I would do one.
Okay, so are you able to see the picture now?
Yes.
Okay, this is the CT of the pelvis.
Yes. So this is the axial film of the CT pelvis, which showed calcified tumor on the left wall of the bladder. Yes, I would like to see the other images. This is the coronal section, and which confirms my finding. The bladder is not very much distended. Can I see again? Yeah, I have a doubt whether there is an extracervical extension on the left side. So I would like to have a MRI scan of the bladder to confirm whether there is any extracervical extension in this patient.
Okay.
And I would like to discuss this in the MDT with the radiologist as well.
Okay, so you are doing an MRI, and how will you quantify a bladder lesion in MRI?
Recently, I know there are talks about BIRET scoring system. So it's basically how much the bladder tumor has extended perivesically, whether it's only the perivesical space is involved or the other organs are involved in the pelvis.
So
basically, it will help for the T staging.
Okay, so how the BIRAT score goes, from what number to what number, what parameters are considered?
I'm sorry, I'm not exactly aware of that. I know that it is being done, but it's not commonly practiced in my trust, so I'm not aware of that. Sorry about that.
Okay, this MRI scan and also your CT scan proved presence of a solid lesion in the left side of the bladder, as you said, with a high possibility of muscle invasion. So what are you going to do?
So I would do a TURBT to get histological confirmation and discuss that in the MDT.
Okay, and the histology confirmation showed a squamous differentiation of TCC with G3PT2 muscle involvement present, no CIS noted.
Okay, so we have a muscle invasive tumor. So further treatment would be a radical treatment. So at this point, I would need to have the staging CT, chest, abdomen, and pelvis. And I would again discuss in the MDT. My treatment of choice for this patient is neoadjuvant chemotherapy followed by radical cystectomy. Other option is neoadjuvant chemotherapy followed by radiotherapy. But in a fit patient at this age, I would incline more towards radical cystectomy route.
Why neoadjuvant chemotherapy?
We have evidence from ABC meta-analysis that there's a 5% survival benefit in neoadjuvant chemotherapy.
So what chemotherapy you are planning for him?
It's gemcitabine and cisplatin.
What type of radical cystectomy you will be planning for him?
In our practice, common one is the robotic-assisted radical cystectomy, but I know that there are trials comparing robotic and laparoscopic and open. There's no survival benefit. There's no survival benefit. This patient also will have a lymph node dissection as well along with the radical cystectomy.
Okay, so let us assume you are planning for radical cystectomy. How are you going to prepare him?
The patient will be consented. In the consent, I would explain him that the aim is to remove the entire bladder and prostate and part of and some of his lymph nodes, and the risks involved are infection, bleeding, and injury to bowel and anesthesia-related risks and DVT and pulmonary embolism. And I would give him the bowels information leaflet in an adequately consented prepped patient after WHO checklist. The standard standard robotic ports are inserted, and bladder is removed with the prostate. And I also would discuss with the patient about a urinary diversion. The common urinary diversion which is done in my practice is ileal condyle. In the consent, I would have explained the patient ileal condyle as well. So after the bladder is removed, the part of the ileum, the leaving last 15 centimeter, which is connected to the ureter, and the left ureter is taken rectosigmoidally to the right side. And
Okay, good. We'll stop there. Good. How do you think you did?
no, it didn't go well. I don't know. The answers are not coming fluently, even though you know the answers. Yeah.
Yeah, it's slightly on the higher side of the spectrum, and I really dragged you into few areas which normally not discussed in by others, so that you are ticking all the boxes, and sometimes the in exam you won't get a little bit of tricky things here and there. Everything will be straightforward one, but this is an exam scenario. I thought you will catch the point that it's a G2 high grade PTA tumor without muscle. I said it quite clearly, and I thought you will take me through the re-TURBT within 6 weeks to get the appropriate TURBT muscle specimen. And but you went for mitomycin. That is one thing which I'm a little bit surprised. So I was expecting to discuss the role of re-TURBT in this patient, and then we did.
Yeah, that's what I was a bit confused, because is it muscle not involved? So this frequently happen in our MDT as well. That's why I said, okay, we want to make sure from the pathology whether muscle is present and not involved or not. Anyways, yeah, I'll take that point.
No, anyway, everything is recorded, so you can go back. I clearly said muscle not present, but I understand it. Sometimes it's very difficult to get everything what the examiner says, and that's why I always advise have a paper. And when the examiner says muscle not present, just make a note of it. It makes a huge difference. Muscle not involved or muscle not present in the tissue, isn't it?
Yes, yeah, I agree.
I mean, even I don't know what I speak, because end of the day we need to look into the recording to see how I clearly placed it. And CT scan is good, and Virat score, you should know a little bit about Virat score, because it's now a little bit commonly used here and there. Almost like prostate cancer, it stages from Virat 1 to Virat 5. When you look into the YouTube, I will try to place a chart which will tell about the it's very easy. Even the diffusion weight imaging, contrast enhanced imaging, and substitutional imaging, it's all divided into again 1 2 3 4 5 with various combinations producing Virad 1 2 3 4 5. Not very much in detail. If you just see this YouTube series, you will get a table. That table, if you revise, that's more than enough. And yeah, and regarding the robotic, yes, it's very important to tell the patients that the oncological outcomes are not much different, but you can say that there is early return to work possibly, and also maybe patient analgesic scores are better, and also blood transfusion is better. Blood transfusion rate is less in robotic. These are all the only three things which is proven. One other thing what I want you to bring is enhanced recovery protocol. So for anybody with radical cystectomy is the one you must bring enhanced recovery protocol. There is a specific nurse for that, so you should refer to that nurse so that they are well seen before. In fact, they may be even given the leaflets regarding the ileal conduit, how the stoma will look. We need to mark the stoma so that the patient is happy with the stoma site, and even we can give a dummy bag for them to wear so that they will come back and say, oh, this is not comfortable, it comes with my the waist bend or something like that. And sometimes patient may wish for left side stoma, so it's very important that the enhanced recovery protocol is properly used, and the stoma nurse is seeing pre-surgery. That's very important. And I'm quite surprised you haven't brought the other methods of exit strategy, like open radical cystectomy, robotic-assisted radical cystectomy with open bladder reconstruction, or robotic neobladder reconstruction. You don't have to say that you're going to do it, but you need to tell the patient that these are all the options available. But in my hands, I have only radical cystectomy with ileal conduit diversion. That's fine. But you should give the patient that there is a possibility of neobladder. What happens after 5 years if the patient sues you saying that this doctor never gave me the option that there is a neobladder option available, isn't it?
Exactly. Yeah, I
Patient is
understand.
not going to say, "Oh, you're not doing near bladder. Please refer me to somewhere." Nobody is going to say that. They are going to accept your ileal conduit, but we should give all the options available. That's very important. Yeah, that's it. Any questions from others?
Mr. D,
Yep.
regarding tumor in the diverticulum,
Mm-hmm.
is it all right for me to say, I mean, if I reach the management part, can I say, like, I will give the option to the patient, one, either radical cystectomy, or two, a diverticulectomy with partial cystectomy, or three, intravesical BCG? Is it
Yes.
right to say like that?
How I will take it forward is I will discuss with the patients the bladder preserving protocols. That those are all the good terms to use to gain some extra marks. Yes, there is a small role for bladder preserving protocol in a patient with diverticular tumor, but it is more for non-TCC tumors like adenocarcinoma or urachal tumor or maybe even squamous tumor, something like that. For TCC tumor, again, because of the field effect changes, still the rest of the bladder has very high propensity, and the radical cystectomy is the gold standard one. If the patient refuses radical cystectomy and opts for a bladder preservation, yes, there is a role for radical diverticulectomy. You can use the word because you're going to remove the diverticulum with all the extravesical fat component and try to preserve the bladder, provided patient is happy with possible BCG for the residual bladder and very close flexible cystoscopy surveillance. Yes, there is a role for bladder preservation. If the examiner is happy to take you in that way, usually the examiner will say, is there any role for bladder preservation, and take it forward. But if you stick that this is a large size tumor with high grade already coming in the high risk in diverticulum, I will prefer a radical cystectomy, it's not a bad answer.
That's great. Thank you so much.
Yeah.
Can I ask something? In CPEX testing before radical cystectomy, in a fit patient with no medical comorbidities, do you still do that in practice or only for patients with comorbidities?
Yeah, the easiest way is any radical cystectomy, since it's a major surgery, we will refer for enhanced recovery protocol, which also has an umbrella cover the anesthetic appointment, if necessary, a cardiologic fitness, and also the usual pre-op preparation like MRSA testing, group cross-matching, etc. And usually they are quite good in deciding which patient needs CPEX testing or not. In a fit patient, 60-year-old, no previous lung problems, staging showed lungs normal, no previous cardiac issues, there is no real need for CPEX testing. Now, people are well experienced in radical cystectomy. I've seen some institutions doing even 3 radical cystectomies in one day. And so those who are doing in a high volume centers, the outcome is very good. You can bring those things into the practice because high volume centers giving better results are proven only in 2 major countries like UK and US, while most of the European countries and Asian countries still the radical cystectomy is done in individual small hospitals because of various economical reasons. So you can bring in that there is a role for high volume center, and of course high volume center will only have the robot also. So you can bring in that. Yeah, CPAC testing you can say only for the patient who is needed, but it is more covered in the enhanced recovery protocol itself. It also involves like attending the hospital on the day in the morning, giving a sugar load which will help the patient to face against the metabolic stress, VTE assessment, lung management in the postoperative period for not only like a simple physiotherapy for the lungs and also early ambulation and limiting the unnecessary blood transfusion, early bowel movement. In case if you keep a nasogastric tube because of the ileal diversion, early removal of the early, nasogastric tubes, and it really makes difference in the outcome.
Okay, yeah, thank you.
Okay, good.
Uh,
If yeah,
just one thing, Mr. Dhanashekhar. Do we wait for the histology to order a CT chest? I mean, what we do normally is that when we see a flexi, on the flexi, if we are seeing a tumor, then we order everything together: chest, abdomen, pelvis with a CT urogram. So, do we have to wait for the histology if it's only for T2?
sorry, I haven't got the question.
So for CT chest, for bladder tumor, is it only for T2 or do we do it for every patient? For instance, like if I see on Flexi, if I see a tumor, then I'll order everything together.
Yes, I agree. Yeah, usually CT chest is reserved only for the high-grade tumors, muscle invasive tumors.
Okay.
But when there is an obvious bladder tumor, just for completion, I also prefer doing CT chest, abdomen, and pelvis because it gives us a completion of the staging, and it's nice to have a look into the chest before you put the patient for anesthesia. And when the patient is going for a CT abdomen and pelvis for staging with contrast, including the thorax will increase the radiation dose very minimal compared to waiting for histology and doing a dedicated CT chest later as a part of completion of staging. So I will err on the side of completing chest, abdomen and pelvis a priori in single request.
Right, Mr. Nash.
Okay. I mean, I haven't brought in because I don't know whether you guys have come across. There are some nice guidelines. For example, the agents like ADX bladder. Have you anyone heard about it? ADX bladder.
No, I haven't.
Okay, ADX bladder is something like tumor markers. So it is now in the NICE guidelines medical innovative briefing. I will try to send you a link for it in our WhatsApp group. And it works by it's a novel biomarker, urine biomarker for mini chromosome maintenance complex component 5. Bit of a mouthful sentence. Mini chromosome maintenance complex component 5. It's almost like one of the multiple biomarkers tried before. The reason why I'm mentioning this is it is there in the NICE guidelines published April 2019. So there is a scenario where there is a good discussion on only hematuria clinic. Purposefully, I've not done it because I want to take you guys to a higher level of discussion. So if you are discussing only hematuria clinic, they will discuss about various urinary markers and narrow band imaging during flexible cystoscopy and using the photodynamic evaluation, and those basic things will be covered. Okay. Okay,
yeah.
Good. I'll send you the details. Good. Thank you for joining. Comprehensive class, and we have completed the bladder cancer completely. Hopefully we will do another session in next few days time. Best wishes for the rest of the day. Bye.
Thank you so much.
Bye.